Okay.
Are you able to see my screen?
Yes.
Yes.
The presentation, right?
Yes.
Okay. So,
So just a minute.
Yeah.
Sorry. Já está no ar? Estamos aí?
Sim, doutor.
Ok. Boa noite, caro associado da SPCOC. Sejam bem-vindos para o nosso segundo Web Meeting da Sociedade Brasileira de Cirurgia do Ombro e Cotovelo, com o tema de transferência muscular nas lesões irreparáveis do manguito rotador. Nós temos no painel Dr. Bassem El Hassan, da Clínica Maio, Fernando Motz, coordenador do Grupo de Cirurgia do Ombro da Santa Casa de Porto Alegre, José Carlos Garcia, coordenador do NAION, Caio Quequia, da Santa Casa de São Paulo, como moderador. Bassem, thank you for joining with us. It's a very pleasure to have you with this web meeting. We know how your schedule is busy in this outbreak with so many virtual meetings. It's a difficult time for everybody all around the world, but the silver line is the opportunity we have great speaker with us. Thanks again, Bassem. Let's start your presentation, lower trapezius in irreparable rotator cuff tear.
So thank you for inviting me again, my friends. I thought after our discussion, because I have been presenting a lot, about lower trapezius over the past, I don't know, 2-3 months on webcam. I'm presenting about the topic, but I changed my presentation a little bit because no matter how much I change it, it's the same topic. So I'm gonna address the lower trapezius for massive rotator cuff tear, but I'm going more into the lower trapezius in shoulder with deficient posterior superior rotator cuff, and I will tell you why I'm saying that, because I'm trying just to go over more material than what I have been presenting over the past, I don't know, several months on webcam and everything else. And I found this animation and I like it on the web just to see it show the 3 parts of the trapezius. Usually there are 4 parts, to be honest with you, because the clavicular part is more anterior. But you can see the lower trapezius, the one we're going to be talking about. This is the Brazil in Mayo Clinic when we had the shoulder tendon transfer course. And I can tell you when they drink a lot, and they're great dancers as well. So they're fun. Okay, so in terms of the lower trapezius and the tendon transfer, I kind of slightly changed like the way to explain the philosophy, why the lower trapezius, how do we think about tendon transfers and everything else. Now, from now on, we say that the scapula is the house of the rotator cuff. It's a house. It's a house that has this muscle. And this house is located on the posterior chest. And from this, the understanding of the location of the tendon transfers and the line of pull become much, much easier. For example, right now, when we look and we start to say the subscap is anterior, the infraspinatus is posterior, supraspinatus superior, when it comes to tendon transfer, in my opinion, we should not say that. When it comes to tendon transfer, we say they're all unit of the rotator cuff. They're in a house, which is a scapula sitting on the posterior chest. So it does not matter what rotator cuff you're talking about, supra, infra, teres minor, subscap. If you want to choose a tendon transfer to be biomechanically correct with a good line of pull, it should be coming from the posterior chest. That is the point. Posterior house, need posterior tendon transfer. And kind of like this is what I thought. I thought if you look at the chest from the front as a cross section, and you look at it from top, and if you have a house in the back of the chest and a house in the front, and you want to connect them, you cannot go across the chest to connect them. But if this is not the connection that you want, this is a type of connection that you want. You want like these to be on the same side, the direction to be very similar, And this is how you do your tendon transfer. And this is applied to any tendon transfer to rotator cuff. But what I realized, as sometime when I'm explaining certain principles, what I realized was that it does not matter if you say anterior or posterior rotator cuff when it comes to tendon transfer, because all the rotator cuff are sitting on the posterior chest. So any tendon transfer, by principle, has to come from the posterior chest. And here, of course, I'm referring more to when we talk, for example, the subscap is anterior, the pectoralis is anterior, but one is on the scapula, one on the chest. So the definition of anterior is completely different. And this is also applied to the posterior superior rotator cuff, because once we get the muscle from the posterior chest, then the more ideal rotator cuff tendon transfer will become that one that has a better line of pull. So, and this is, I'm showing also houses. It's very nice to connect the houses on the same side instead of crossing from side to side. And this is how, when we start to do the dissection early on, I'm talking 13 years ago, when one of my partners asked me what we can do for brachial plexus patient, and I was dissecting. And of course, the house principle, I did not have it at that time, but very sincerely, if you look at this, the scapula as a structure. Don't worry about the rotator cuff, just as a structure, as a triangle. And you look, what if you have a matching house next to it is a trapezius. Even though the latissimus is a good one because it is coming from the posterior chest for the posterior superior rotator cuff. However, in terms of line, this is almost the picture I showed you before about connecting the houses next to each other. They're on the same side, the same line, and everything else become much easier. So if you look at the trapezius as a triangle, and if you look at the rotator cuff, does not matter posterior, superior, inferior, because they all are on the scapula as one structure, then believe it or not, the trapezius become the better transfer to any of the rotator cuff. But specifically the posterior superior rotator cuff, because if the scapular surface on the chest, the trapezius on the chest, they line in parallel and become very easy to transfer this tendon from here to here. Now, if you notice here, if you peel the muscle from around the infraspinatus, this is the infraspinatus, you can see this nice, very nice long tendon. This is the infraspinatus tendon. It is very nice long tendon. So it is very, very possible and easy, and this is how we used to do all of them, to transfer the lower trapezius tendon directly to the infraspinatus tendon. To reinforce this principle, again and again, this is a cadaveric dissection. Only we dissected the lower trapezius. Remember, this is the house of the rotator cuff, the scapula sitting on the posterior chest. So if I want to reconstruct these with a very nice line of pull, the trapezius will make a perfect kind of transfer. This is another one. Again, this is infraspinatus, peeling the tendon, just reflecting a little bit the deltoid, just to show the line of pull of the infraspinatus. Look at this nice, very nice tendon. Latissimus is good. It may depress the head, but the line is more vertical. So even though they're coming from the same side, is good. Now we're gonna start to focus more on the line of pull. And you can see now the line of pull. You can do direct transfer of the lower trapezius to the infraspinatus. And this is, by the way, a surgery we did in Brazil during the meeting, if 2000, was it 18? I forgot, maybe, Jose maybe remember. But we did the patient with brachial plexus, and we did the direct tendon transfer of the lower trapezius to the infraspinatus based on the same principle, because you can see very nicely how the tendon leg match. And this is what we spoke about a lot before, and this is my prior presentation. I tried to talk a lot about what's the advantage of the lower trapezius. I think this is a huge advantage. In addition, it has the same strengths, the same excursion of the infraspinatus and the rotator cuff. And it is very easy to train, because anytime you external rotate the shoulder, the lower trapezius fire. Now, how do we do it? And why do we do it? We do it then for all this indication. Brachial plexus injury, massive irreparable rotator cuff tear, and also if you have musculotendinous tear of the infraspinatus, it will be a perfect indication. And these are very uncommon cases, but we see them. You see them sometime in your clinic. and in patients who have an isolated paralysis of the infraspinatus. So these are patients, if you have the tendon, you can do direct transfer. Otherwise, you need the typical transfer that we do for the massive posterior superior rotator cuff tear. And I thought, for the sake of the time that you've given me, just to go over the technique, which we talked about it a lot in the past, but I think it will be good to reinforce here. This is principle, I think all of those who are doing lower trapezius now, they are following. You put the shoulder in a certain position. Remember, the house of the rotator cuff and the trapezius insertion are on the scapula, right? So anytime you move the arm, the scapula is moving. This house is moving. This is one unit. So once you position the arm in one position, don't change it anymore. This position, you can, and then you do your marking. After you do your marking, because otherwise, if you did your marking and you change position, it's gonna change. Then when you start to do dissection, you may not find the structure that you want. So position it in traction. It will pull the trapezius better because you are in the B chair position. Of course, you can do it lateral. We can talk about it in the discussion. But in this position, B chair, it is much easier to pull the arm forward in front of the patient. It will pull the scapula, it will pull the trapezius, and keep it in that position. Then you do the marking. Now, the teaching we have been using all the time, and a lot of surgeons have been following, and I think it's working very well. It is this small angle between the medial spine of the scapula and the medial border of the scapula. So what I call it armpit. Why the armpit? Because if you raise your arm, you have like an angle, and this is like the armpit. This is the armpit, your armpit, and this here, if you put your finger here, there's a soft spot. It's almost like an armpit. So if this is your arm in an abducted position, and this is the angle, this is where the lower trapezius all the time. Incision-wise, the marking is, after you mark this one very well, you this angle, you go at least 1 centimeter or 2 distal to it, and you make your marking. The marking, let's say you did 5, or let's put it 6 centimeter to make it easier. You do 6 centimeter, ideally maybe 2 medial, 4 lateral. So aim more the incision lateral rather than medial. Why? We'll talk about it more later, because after the harvesting, when you open the skin and you harvest after the harvesting, and you try to attach the tendon to the lower trapezius, all the attachment is going to be in this area, more lateral. So if you made a vertical incision, which I did in the past, you can still do it, but you can struggle with it more. The dissection may be easier to get the trapezius, but later when you pull on the tendon to attach it, it becomes more lateral. You don't see as much, because if you make an incision vertical here, and your work here become harder to see. Okay. Now, so this is it, and in most of these videos, especially the trapezius harvest itself, it has very little, I very little did any cropping in it, because it's really very quick. Sometimes the patient's skinny, it takes a few minutes, and that's it. The first step, we always say it, I'm gonna repeat it, doesn't matter. No matter how skinny the patient is, you're not gonna open and see the trapezius. Surprise, look at it. This has never happened to me. I've done hundreds and hundreds of these. I've never seen it once. But once you open the skin and you open and you retract the skin, there is always a layer of fat. You pull on it, you don't go straight vertical on this fat, you go parallel. Like as you're pulling with the cautery, it almost peels the fat off your tendon. And you do it until you see a tendon. You don't convince yourself that you're seeing it. And the tendon, remember, is gonna be down this angle here. You're gonna find it here. There's no way. Now you take some of this fat and take a look. Can I see it? No. So you keep on taking until you start to see structure that look like muscle or tendon. I pull on this, there's a structure here. I know the trapezius is here. It has to be here. When you pull, you see like a cord-like structure. You see a whitish structure here. This is a tendon. Okay? So if we look at this angle again that we spoke about, the trapezius has to be here, even though it's not very clear, but I know it is here. And you can see the border. And this is the armpit that I told you about. See, this is like the point, the soft spot almost, or armpit that I told you about. And here I always try to show that if you do your marking very well, you're dead on the trapezius. When you don't see it very well, because there's a layer of fat on it. Once you get the fat, you'll be able to see it. And you start, if you see more fat, you take more fat. If not, it's okay. Now you know there's a tendon, you see the tendon, and you see the muscle, now you know where the trapezius is, and become very easy to detach it. And that's it. You detach and you detach. And then when you pull on it and reflect it, you'll be able to see the tendon underneath. Now, I use cautery often. Why? Because I follow the contraction, but I never use the cautery non-stop. I never take the cautery and push all the time. It is buzzing. Why? I'm feeling the contraction. It's not the best way, but it's a good way. You feel it because the contraction stronger, you know you're closer to the nerve. And this is why you buzz only shortly, because you want to make sure you don't injure the nerve. The nerve is almost always, in 90% of the time, with this, especially with this arm in this position, it's around 2 centimeters medial to the medial border of the scapula. And now you see after we detach it, and you see now at the lower trapezius, you can see the tip of the lower trapezius because the incision is small, okay? And we can see the tendon underneath. You can see it very well. I always suture the lateral aspect of the tendon. This is another patient, also very little cropping, but this patient is more fluffy. Remember, this is fluffy 3. This first patient was fluffy 2, okay? Now, the same. This is the steps exactly. Incision, put a retraction. If there's any bleeding, I will cauterize it. Then there's a fat. I pull on the fat. The same exact steps. I pull on the fat. I pull and pull. Look, this one I was lucky. Even from the first pull, I can almost see something like a tendon. You can see this. This is tendon and muscle. That will make you feel much better instead of just dissecting and assuming stuff, you know, because you're pulling out on the fat. And now I put this retraction again just to make sure I'll be able to see. Now I can see it. And very sincerely, like it usually doesn't take more than a few minutes if you do the accept correct and you have the good exposure. And I always put a suture on the lateral tendon, mostly to imbricate it, because later I'm gonna pass graft around and I wanna pull on it to give it attention. Now, this is second step. Again, I'm sorry for those who have heard this so many times, but it's not bad to have repetition. This is second step. This patient has no infraspinatus, by the way. She has complete fatty atrophy of the infra because of musculotendinous tear. But I always open the infraspinatus fascia. This fascia is infraspinatus. What's characteristic about this fascia, it comes and merges with the posterior deltoid. So what means if you open it and you go below it, you are between the deltoid and the infraspinatus. So it comes on the infra and on the deltoid. If you take it out and you go below, you are between the deltoid and infraspinatus because the fascia comes on top, superficial. So I always make a big hole in it. I pull on and I cut this fascia. And if there's muscle, if it's not working, this patient, you can see there's a fat, there's nothing, and I make big hole. What's the problem? There's no issues. You can make it as big as you want. And you can see here, there's no fat, muscle, there's nothing. In fact, you can see the scapula bone. There's no muscle at all, which is bad. Like she has no muscle. So once you do this one, this is the opening, and this is that we show all the time. If you go here, that's it. You go between deltoid and infra, you're in the subacromial space because you are between the deltoid and the infraspinatus. Now, this step of the case always is in the beginning. So I'm telling you step by step how we do it. Before even I enter the room, the step is done because we know this patient advanced fatty atrophy, no infra, we know is gonna need to be done. So this step is done in the beginning of the case. Like one of my member team is in doing this step. We usually put them on the Arthrex tower, and then we pull on the tendon and we put suture, Krakow sutures ×2, and then we color the top of the tendon. And this is done even before I enter the room or as I go to the room. And my advice to you, it's up to you. I always, when I take the graft to thaw it, because it's iced, because it's cold, I put it with saline and 1 gram of vancomycin. Why I do that, even though I trust the source, but the only time I had infection 12 years ago was with the graft. Whether it is from it or not, I don't know. Since that time, anytime I use a graft, allograft, I use vancomycin, which is, there's no harm, but at least I feel better. And I haven't seen infection since. So you have 2 Krakow sutures, and you have we take coloration of the, you do coloration of the top of the tendon. If the patient has, like we know there's no, like this patient doesn't need even rotator cuff repair. Almost always we do 3 portals. Usually almost always the posterolateral, you can see I go in from it to the same entrance I showed you. If you do this entrance very well, you open it and the patient had no prior surgery, it's a very easy path. You go from the subacromial space, deltoid infra, and you are into this area. And I usually use this large grasping clamp. There are a lot of technique to pull this tendon in, but this is the way I do it. There are a lot of modification now because surgeons are more and more doing this surgery. And I pull the sutures from the posterior portal. But it depends now where you want to attach your tendon. If you have infraspinatus only, I attach it on the lateral aspect of the infraspinatus footprint. If it is a posterior superior rotator cuff, I attach it to the anterior footprint of the supraspinatus, and I'm going to show you this as well. These are the three portals I almost always use: an anterior, almost anterolateral portal, a posterior lateral portal, and a lateral portal. In the beginning before the tendon is passed anteriorly, we put an anchor slightly posterior on the footprint, medial footprint of the supraspinatus, and we keep it in place. This is coming from here, because I use this anchor, the suture later for a medial to lateral kind of flow compression. And now I'm bringing the tendon. This is in a posterior superior. This is another example just to show you. And we bring the two sutures I showed you. You have two in the Achilles tendon. One is medial anterior, one is medial lateral with a swivel lock. And then the medial anchor, the slightly posterior anchor I placed, while I'm pulling on the anchor, I take it from medial to lateral to compress it. So you have two anchors anterior and one anchor medial to lateral, slightly more posterior. And you can see now this is a medial to lateral anchor. And you can see now we can pull on the tendon if you want to tension it, but you can see it. And here we put the shoulder. We position the shoulder in posterior superior. I always put them in abduction. This is very important because I get asked this question all the time. I put them in this position when I tension it, because this will shorten the distance of the Achilles tendon, and I place enough tension on the tendon to repair. You can flip it as almost pulver taft. You can pull on both sides. You can, the way you want, but I almost like to go inside the tendon and make it pull. Either pulling it on both sides as you're keeping the shoulder in abduction, external rotation, or I flip it on in itself and do a pulver taft. The key, you need to have a nice, strong repair. And then as you notice, I took it from abduction, external rotation to a deduction, external rotation at the end, because this will tension the graft very well. And with some motion, you can see very nice motion going in internal, external rotation of the lower trap. Okay, so this is like step by step the technique for the audience in case of, because I get asked about the technique, and many times I go through material and we don't go through the technique very well. I'm not gonna show. I have anyone who's interested, I can send you tons of videos about patients and their functional outcome. Like this patient has a massive posterior superior. You can see slight difficulty in abduction, and she is super, super happy with all her motion. This is now in press. This paper is the outcome of arthroscopic assisted lower trapezius transfer in 41 patients. Average age is 52. That's important, by the way, because I see many people who are presenting about massive tear in patients 60, 70 and above. Most of my patients are between 35 and maybe one of them will be 65, 70 if he's a strong farmer, but a lot of them are really younger. And some of them have pseudoparalysis, ER lag, and subscap tear. Does not affect the outcome as long as it's reparable. And a lot of them, they have proximal migration. Also, it does not matter if they have proximal migration or not. And 37 patient has a significant improvement in all parameters. And the shoulder external rotation specifically was really excellent in almost all of them. And 17 out of 19 had reversal of pseudoparalysis, 2 have traumatic rupture, and 2 needed reverse shoulder arthroplasty. Now, I'm not sure, do I still have time?
Yeah, okay.
Yes, of course.
Okay, because I thought just like this will give a perspective about what we have been talking about lower trapezius over the past few years and in this meeting. And then I'm gonna add another level of it. I get asked this question all the time. So we're talking about also the efficient posterior superior rotator cuff, and I know a lot of surgeons rely on the implant to get them external rotation. Unfortunately, regardless whether you have medialized, lateralized implant, you don't always get external rotation. And the patients who are frustrated are those who internal rotation they had no external rotation, they have no flexion. This one has paralysis as well, has the deltoid weakness. And now after surgery, they lost internal rotation and still they don't have good external rotation. Now, I have some patient who had the reverse and brachial plexus injury, And they tried also like with different, they thought the implant, the lateralized implant gave external rotation, did not. And I have a patient who had the surgery, came back, say, you know what, like I'm okay, the flexion is okay, but I cannot do my stuff. I have to push my hand to be able to do what I want to do because they cannot do external rotation. So in these patients, the key for me is when you have real ER lag before surgery, as if the patient have imaging showing that they don't have teres minor, you should not promise the patient external rotation just from the implant. You should tell them, hopefully the implant will give you external rotation, but it's not guaranteed. It's almost like what you talk about subscap and internal rotation in implant. You cannot promise patient internal rotation after reverse, even if you repair the subscap. And in my opinion, it's the same for the ER with the implant if you don't have any external rotation before surgery. Now, what do we do for these? Like the typical transfer is laparoscopic, like Pascal Ballot started with the 2 transfers, but then he noticed that in some patients, they really significantly affected their internal rotation, and he started to do latissimus transfer only. For me, if I do latissimus transfer, which sometimes I do, but most of the time, I just want to mention that in the secondary setting, when patients have failure of to get external rotation after surgery from reverse, I almost always do lower trapezius. I'll show it to you. This patient specifically wanted both external and internal rotation. So he has some difficulty in internal rotation and he has no external rotation. And I discussed with him the option. I told him I can do lower trapezius from the back and maybe latissimus from the front, or we can just try to do latissimus to help you. We'll keep the teres major and I can raise the pectoralis. This is the only time I use pectoralis for internal rotation in reverse because I don't use it in non-reverse cases. And this is usually what we do. We get the pectoralis, we detach from its insertion, and you can see like we're gonna take it from lower to higher, and hopefully it will give some internal rotation. And this will give a very nice exposure to the latissimus because latissimus, as you know, is here. I honestly have never detached both at the same time in this setting, never, because I always worry about it. And I don't go through the teres major, I go deeper to the teres major, like what you do it, how you usually do it for rotator cuff, because I think going through the teres major will affect also the outcome. And then you go around the shoulder, from distal to the teres major, not through it. This is a suture. And then you pass the latissimus from around. Notice the teres major is intact. I'm not through the teres major, I'm distal to teres major. So hopefully the effect on the teres major will be there. And I don't go too proximal with the latissimus. It worries me because partly it may affect the flexion when you put it higher, and it may affect also internal rotation. So I put it slightly lower because the leverage will be less, and I attach it. You can see it here attached with an endo button in the front. And now I have the latissimus in the back. I take the pectoralis major and transfer it proximally to the front. To be honest with you, it is not very impressive with the pectoralis major transfer. I haven't seen anything really impressive, but it may give you a good internal rotation from an external rotated position. It will, in my opinion, it will never help with the hand behind the back as much. I already have 2 sutures in the pectoralis major, and I use the endo buttons ×2 to suture pectoralis major more proximally. So now we have latissimus from the back, pectoralis from the front for these kind of cases, and you can see how it looks. And the patient all in all did very well. Still, his internal rotation was not the best. Teres major is a possibility if you don't have latissimus, but I don't do laparoscopy myself. Now, what about the lower trapezius? This is something I do it routinely now for patients with the reverse who came to me with the reverse and did not have good external rotation. I don't do it in the primary setting because I don't feel it is really necessary to go from the back with an additional incision while the latissimus is in the front, and it's very easy to take it. It takes 5 minutes and you move it around. But the line of pull is the lower trapezius, honestly, is very sexy. Like you look at it, you look at the reverse shoulder arthroplasty, it feels like this is what you want. It wants to go to the reverse and give you this very nice external rotation. Of course, in the reverse, you're not doing you can do it arthroscopic if you want to. I don't find the point because you have already big incision in the front. So I go from the back, I do a split between the 2 parts of the deltoid. I attach the same way. I attach the graft first, I pass it and attach it to the tendon after, the trapezius after. But the attachment, I don't use anchors. I only use endo button. Why? Because when you put these anchors, when you put the suture in the Achilles tendon, If you have an implant, many times you don't have enough bone proximally. But when you drill with the endo button, you can go around the implant, you can cheat around to be able to go from the back to the front. It will give you a nice leverage this way. So here you can see the same way. Oops. You can see, again, we prepare the Achilles tendon. You attach it with the endo buttons because you'll be able to go around the proximal implant. And the same technique as I showed you before, but of course a bigger open incision. And here I always do lateral approach. Sorry, a lateral positioning, because it's much easier to see everything instead of putting pitch chair and you cannot see as much. And you can see very nicely the pull, a very nice line of pull, completely different than the vertical line of pull. So some of the advantage of this also, is not going to affect the flexion. If you were one of those who believe that latissimus, if it's tight, it may affect flexion and reverse, this one will not affect it. And you can see here very nicely after you did the repair how this is going very nicely. So one last thing, this is because I've done more and more of these. Sometimes what I've done, if the tendon is long enough, what usually we do after I pass it here, I tighten it, I repair it, and then I go back inside the shoulder. So you can pass it again. And now you have you're tightening your transfer. Look at how nice it is. And then you repair it again. It will be almost a double fixation very nicely. So this is a patient who has a paralysis. I told you the deltoid is weak, but you can see her flexion. You can see now her external rotation. This external rotation, you're not as much to guarantee in a patient with latissimus transfer, especially if they have a deltoid weakness. This patient has complete paralysis, and I did for him pedicle pectoralis as well. He was beyond happy. He could not believe that he was able to external rotate his shoulder after like 5-6 years of his injury. And this is a patient post-op. You can see also they don't have to squeeze to do any trick to get their external rotation to the side. And this patient had lower trap, then requires, I think, reverse, but now you notice her external rotation. Like they'll be able to do it without much, especially if they are skinny and they can external rotate. This is very good because usually if they are more fluffy, they can put their arm on the side and they push their arm with their belly. But the skinny people, they cannot do it without the transfer. Anyway, I've done 14 so far of these, 12 male, 2 female. But average age, of course, different. But notice 27 to 71. This is completely different category of patient. 11 lower trap, 3 latissimus. 11 patient has lateralized implant, 3 head medialized. This is for everyone who's listening. This patient that I did transfer on, 11 had lateralized implant, 3 had medialized. Okay. I'm still very, as you notice, the follow-up is still short, but at least we have follow-up, no complication. Thankfully, I hope it will stay this way. And all the patient has significant improvement of external rotation, average 45 degrees, range from 30 to 70. And we notice, even though the number is small, much better external rotation with lower trapezius compared to latissimus, but of course the number is very small. Again, I want to thank all of you. And this is, if you remember, Jose and Fernando. See how this is when I was in Brazil. We ate a lot, by the way. I gained weight when I went to Brazil. And he used to drink a lot. I used to eat a lot. So it doesn't matter. And I danced a lot as well. Anyway, thank you very much.
Thank you.
Thank you. Bassam, could you share your webcam?
Yes, sure.
We have some questions from the audience. Can I ask a few of them to you now?
Yes, absolutely.
Okay. One of the guys has asked if you ever perform an acromioplasty when you do a primary transfer.
Bony acromioplasty, I've never done it, but it's for the educational purposes. I want to mention that for those who see a lot of shoulder patients, there is one category of patients who are a late presentation of obstetric brachial plexus injury. These patients, they have bony changes of the coracoid and the acromion. Some of them are also under dysplastic category. These are the only patients. Sometimes I do acromioplasty, occasionally I do acromial osteotomy, like I corrective osteotomy, but these are completely different category. In my practice, I rarely find a reason for patient to have massive rotator cuff tear. They're already proximal migrated. I feel they already eroded their acromion. to go in and try to do anything for the acromion.
And what about the post-operative immobilization? Do you use any special slings?
Yes. Yeah, again, I'm sorry, this presentation, I try just to change my presentation from before, but yes, of course, all these questions, we can talk about them. In my patient, almost always, all of them between 6 to 8 weeks of ER, they are in this position for 6 to 8 weeks. Now, some of you might find it difficult, I know, but you know, it's really ever, for patients who are really have a problem, I never had an issue with them doing the brace for that long. And some people ask me, but are you worried about stiffness? Well, I tell them I rarely see it, but I'm thinking about it. Why? Think about it. Why I don't see as much stiffness? If you think about it, most of the surgery we do, we put the patient in a sling, right? When you put the patient in a sling, what happened to the rotator interval? It closes. If there's any chance that you can scar your rotator interval is an internal rotation. When you are in this position, the rotator interval is stretched, is open. This is why, in my opinion, they rarely have true stiffness. Even though inferior capsule maybe a little bit, but this is only in a really older patients, but I don't see it. And then after the 6 to 8 weeks, they start aquatherapy only for motion. I don't do stretching the first 4 months at all. Why? Because sometimes in the therapy protocol, they like to stretch, which I think is okay. But remember, stretching, the tendon is attached in the back and tight. And it requires time to heal very well. When you start to stretch it, it may stretch, you may lose excursion of the tendon. So the first 4 months, I don't stretch. Only active assisted, aqua, no strengthening. After the 4 months, I feel better. They can start gentle stretching. And they have better motion. Their passive motion, usually they don't lose it. They start to have better motion. And we start strengthening after that. At 6 months, usually I tell them, you can do whatever you want to do. But I notice even those they do really very good, only the first 2 to 3 months. In fact, in the past webinars, I presented a case. I did it with my friend Hashim from Barcelona. And the patient 3 months, she was like doing this. I have a patient from Chicago. He's sending me, a friend of mine in Chicago, he's sending me a patient 3 months doing push-ups, which I don't do that. But patients really do well, pain-wise and function-wise. I usually tell them 6 months you are free, but they keep on improving even after a year. But the 6 months they are doing very, very well.
It's hard for us in Brazil, sometimes depends where we come from, to have access to allograft. Do you have any experience with autograft?
I don't, but to be honest with you, if you use hamstring, it's really great. Like it's really, really great because hamstring is an autograft. If you take a long one, like for example, Philippe Valenti right now, who's a friend of yours as well, Philippe Valenti routinely uses a hamstring and he's very happy with it. But he always takes a special length so that he'll be able to double it. And yesterday, in fact, one of my prior fellow, who's like, I don't know whether you know him, Edward Alentron, he's from Barcelona. He's very, very good guy. He showed also technique of the hamstring. He doubles it, but he make the loop of the hamstring on the medial side. So he can pass the tendon of the lower trapezius through this loop, which is also very nice, almost pulver tuft kind of technique. To tell you his story, and because Philippe Valenti is a very good friend of mine, Philippe very early on, he was a little bit skeptical. We used to do, we come to Brazil to Recife to do mission work, but all of them brachial plexus. Me, Philippe, Jean Cani, JD, and we come and do like a lot of patients, but all brachial plexus. And when we start to do, and he used the lower trapezius routinely for brachial plexus all the time. When we start to do it for the rotator cuff, early on, he told me, I think latissimus is good for flexion, lower trapezius for external rotation of the arm to the side. So he has very specific indication for lower trapezius. Lately, and he feel if the patient have almost pseudo-paralysis, limited flexion and ER, he used to do both. He used to think latissimus on top, lower trapezius on the side can help both. But then he told me it did not make any difference if I did lower trapezius alone or I did them double. And for the past patient that he's now going to publish about, and he presented about it in the ASES, and he has been presenting about it in the webinars. Now, for him, advanced fatty atrophy, supra-infrateres manner, it is lower trapezius transfer. He does not add any latissimus or anything else, and he's very happy with the outcome. So, and he used hamstring all the time, no Achilles tendon, always hamstring. George Athwal used hamstring all the time. So.
Great, wonderful. And do you have any experience using this technique to treat patients with instability secondary to an irreparable cuff tear?
It says, again, this is all biomechanics. This is all the same understanding. Dynamic instability, it's common in patients with a massive posterior superior rotator cuff, especially if they have teres minor not working very well. If the subscap is strong, many times they try to move and they pop the shoulder, but this is not true instability. This is only dynamic instability because they don't have the force couple. So for this one, when they say, yeah, my shoulder is popping in and out and they cannot function, we should talk about them more, but to be honest with you, it's the same. Because you just need to restore the force couple. Once you push the infra from the back, they don't become unstable anymore. These are not the true instability, they are dynamic instability.
Does anyone have any other question?
Bassem, do you usually do with superior capsule reconstruction with your transfer of the lower trapezium?
I don't, and this is very common question. I'm almost like Philippe. There's a period of time I did not do the true SCR. I just did I start to use, you notice right now, I take the thick portion of the Achilles tendon, I attach it on the humerus and the thin portion medially. At one time I said, you know what, let me do this. Let me take the thin portion, double it, and make it in a shape that I can attach it on the humerus and on the glenoid. So I do both. I attach it on the humerus and cover the glenoid. And then I do the same technique. Honestly, it did not make any difference, except I added more anchors. This is number one. Number two, which also I did not show here because I want to show you technical more aspect of this, is I have maybe 2 patients who I don't always take the biceps out, by the way. If the patient pre-op, mostly they have weakness, they have no pain of the biceps, and I go in. The bicep does not look inflamed, I keep it in. I don't take it out necessarily. But I am a big fan of taking the biceps out if I know it's causing pain, definitely, like not against it at all. I have 2 patients that needed biceps after 3 years, not immediately, 3 years. And those patients had no cuff, like it was naked, empty, bald. And I did not do anything except lower trapezius, nothing else. If we have time, I can even send you, show you the intra-op. I went intra-op just to do the biceps, and I was surprised because the whole area was covered completely. Like the naked area that we had before, it was completely sealed. There's no opening whatsoever. How to explain it, I'm not very sure, but I'm a believer right now when the shoulder is dynamically stable, I think the body can reform a pseudo capsule that covers the shoulder itself, because this is my belief right now and because I have the proof about it. So this is also another way why I don't do it. Now, in patients who have failed SCR, we are in the process of reviewing our patient. Maybe I have either 10 or 12. I have a 10 or 12 patients who had on average 3 surgeries, some of them 4 or 5, some of them 2 or 3. But one of them was SCR, which is failed. And I've done for them lower trapezius, and they were able to regain their function. So I have it in reverse. In those patients, if the SCR looks nice, detached from the humerus, I reattach it and do the lower trapezius. But I would say in 80%, I'd either take it out or because it's already gone or fragmented.
We have another question from the audience. It's
Yes.
about your technique in the pec major transfer.
Yeah.
You do it over the conjunct tendon. Why you do it?
Well, it's a long story with the pec transfer with me. I honestly don't do pec transfer except in reverse shoulder arthroplasty. I never ever do pec transfer except in reverse shoulder arthroplasty. Not because it is, I cannot say it's not a good transfer because it has a very good track record, Herbert Trash, Christian Gerber. But for me, I told you, how will I, if I have a house of the rotator cuff sitting on the posterior chest, how am I going to use an anterior chest muscle to replace any of the rotator cuff? But reverse is slightly different because the reverse is a locked mechanism. Is not any, you cannot even think the reverse is the same as a regular shoulder, because we are not built or created with the reverse. We are built with an unstable joint that requires a lot of muscle to balance it. So when the shoulder is locked, there's nothing, it's locked in place, then maybe this muscle, it can leverage on this lock to give you some internal rotation, even though it's not coming from the posterior chest. This has been said, I will never take myself a chance to pass the whole pectoralis deep to the conjoint in patient with a reverse, under tension, and risk the musculocutaneous nerve. And in my opinion, it will not make any difference. My opinion.
Okay.
And what would you say is the main complication of this technique? Someone has asked this.
The pectoralis transfer?
No, sorry, about the trapezius, lower trapezius.
In reverse or in general?
General.
In general, very honestly, very, very low complication rate. As I told you, 13 years ago, I had one infection in patient Fluffy 4. And since that time, I started, Jose, stop laughing. Since that time, I started to use the Achilles tendon with the vancomycin all the time. I haven't seen seromas. Infection, I haven't seen it. I will tell you, it is mostly delayed complication more than anything else, which means if the patient have certain expectation, you did not achieve them. In patients who have arthritis, Hamada grade 1 to 2, these are the tricky ones because you don't know where the pain is coming from. Is it coming from the rotator cuff tear or from the arthritis? These sometimes I tell them, you know what, I think up to Hamada 2 it will work, but I cannot guarantee how much the arthritis is going to give you issues. This is mostly what I would say. I would say later failure to achieve patient expectation in terms of pain and function, which is really very, very low. And I am very honest. It's like arthroscopy. It's a very low complication. Passing this tendon around is not too bad. The incision in the back is not too bad. This area is very bloody. This area is not an axilla. You know, you're not doing latissimus in the axilla. You're not touching the P acnes. You're away from the acnes. So I think I would say it's relatively very low rate of complications.
Okay, thank you for your presentation. We will have a discussion case. If you want to stay with us, it's a pleasure to us.
Is it in English? Is it in English or in Portuguese? If it's in English, no, it's in English, I'll stay. No problem.
Good.
Okay.
Okay. Well, I will show one case. This is a 62 years old, right shoulder pain and dysfunction after trauma. As we can see, he has a slight line shanton break. He has a probably irreparable supraspinatus tear, a probably reparable infraspinatus tear, a good subscapularis, and we can see teres minor with fat tissue, fat infiltration. So is a supra, infra, and spinatus tear with teres minor degeneration. His shoulder examination, he has a lack of external rotation, a leg sign. He has a drop arm sign, a long head of biceps tear from long ago, and a drop arm sign, positive. And what we done? We done a lower trapezius transfer for external rotation, exactly what Bassene has shown. A longitudinal, horizontal skin incision along the posterior spine. We drape the knee to harvest hamstring. We done a lateral incision with deltoid splitting. We check if the cuff is repairable and go for the posterior part to harvest the lower trapezius. The arm pad tissue, as Dr. Bassene says, lateral border of the lower trapezius. We have to check where the lower trapezius insertion and the posterior delta origin. We detach the trapezius from the spine. The junction between the middle and the lower trapezius, check the innervation in the medial border of scapula. Then we put 2 crack-up stitches. It's a nice tendon, as Dr. Bassen showed us. Then we repair the cuff, if we be able to do it, with transosseous suture. Then we do the tunnel below the deltoid. We do a double hamstring. We pass the hamstrings below the deltoid. Here I use one swivel lock anchor to fix the hamstrings at humerus, and then we fix the hamstrings in the lower trapezius. We can do some stitches around the graft and the cuff to do like a tenodesis effect. Then we can hold the trapezius with the hamstrings. It is a very important step. We have to do a very tight and heavy sutures. Putting sutures with trapezius and hamstrings. Then I bend the trapezius and suture itself like a chain. Then we internal state the arm to check the excursion, and you can see the lower trapezius moving on. And this is the final 4 months follow-up result with a very good elevation. Then we can see preoperative leg sign and postoperative with he's restoring external active elevation, but check what is interesting, he can raise his arm and keep in abduction and stern rotation. Thank you.
Excellent. Very sexy.
Thanks, Professor Bassen, for all your knowledge.
Very nice.
Jose, your comments.
I have a question about, do you think for Fernando and for Bassen, do you think there's no place anymore for latissimus dorsi transfer for this massive rotator cuffs there?
Fernando, go ahead.
Well, I think in young patients with irreparable supraspinatus and infraspinatus, there is a room from latissimus. We still have room for latissimus. So they don't restore strength in stern rotation, but they can put their hand in space with, how can I say, without symptoms in an uneasy way. So I think there is some space, still space to latissimus. I think that's the very good indication for trapezius, lower trapezius, is when teres minor is degenerate.
So Jose, I agree with what Fernando said. The latissimus has a very good long-term track record, and nobody can say anything about it. For me right now, the only time I do latissimus in reverse shoulder arthroplasty, because, and in primary, not revision. To be honest with you, and you notice, Fernando, and you know, Jose, I probably have done also lower trapezius and the rest. Once you start to do lower trapezius and like you get used to it, I don't know whether you feel you can go back to the latissimus, except you have a really excellent result with the latissimus. I don't know why, for some reason, myself, I did not have very good outcome with the latissimus, and maybe because of the indication, maybe because I have a lot of patients with pseudo-paralysis and stuff like this. I respect highly everything what Christian Gerber published about and others. And for me right now, I don't have place for latissimus except for reverse shoulder arthroplasty. And I think time will show that if the trapezius had tendon long enough that you don't need augmentation, I don't even think anyone should do any more latissimus. The only thing is latissimus, advantage of it is it has its own tendon. You can take it all the way. You don't have to augment it, number one. But disadvantage, you are all very good surgeons, but not everyone is comfortable dissecting the latissimus from the axilla, go all the way up, getting the tendon and stuff like this. So I think time will show. Time will show. I think there's a place for both right now, but for my practice, I do it only in reverse.
Thinking about the directions of vector, because the trapezius is more horizontal vector and the latissimus dorsi is more vertical. And if the red is more superior migration, don't you think that latissimus dorsi has more action to down the head?
I used to think so. I don't anymore, honestly. And like what would be the best way to say it? Biomechanically, we wanna believe this. We wanna believe latissimus come up and it depress the head down. But we have seen a lot of cases where you do latissimus transfer and post-surgery, the head doesn't go down. And not only this, if we think about it really, if you have infraspinatus in patient, but you don't have teres minor, the patient can go in both directions. By exam, if someone has teres minor atrophy, completely atrophy, which many times we find it incidental, they can abduct external rotate and external rotate on the side. If the patient have no infraspinatus, but they have teres minor, most of the time they can external rotate to the side, but they cannot external rotate at abduction, which means if we have a muscle that can restore the infra, it can take care of both. And in my opinion, it is not the depression effect. It's much more the force couple effect of both. That you have subscap in the front and muscle in the back that will hold the head in place. That is my thinking. And this is why Philippe Valenti, when he started, he used to think this way. He used to think latissimus to depress the head, the lower trapezius to do this. And then he realized it's not making any difference. And now he does only lower trapezius. But I would say time will show. Like we need more time to dissect the data and probably be able to come up with more answers.
And have you ever had to perform a reverse arthroplasty after having done a trapezius surgery? And if so, did it make
my data? I did show it in my data, and I would say they have the best outcome. Because the trapezius is in place, and once you put the reverse, it's already healed. You don't have to worry about it, and they have the best outcome from it. Outstanding outcome. Yes.
Okay. In a sequence, Garcia, could you present your case?
Yes, I will. This will be. I just to close my camera to try to make better this transmission. And this will be the first crossfire between my friend Bassem, because I know he will not agree with me, but it's still discuss. It's good. Hi, Betty. That's a cervical pain patient from 2016, become worse after infiltrations with corticosteroids in the posterior cervical region. The patient evolved with pain, loss of the equilibrium of the superior arm over 80 degrees, with a deformity in the wings scapula, with movements that require retraction. Here's the patient. It's the exam of the patient, the passive and active exam of the patient. You can see she has elevator scapula, the rhomboid minor, rhomboid major, latissimus dorsi, and it's a dynamic exam of the patient. You can see there, you can see all these muscles, but you can't see the trapezium. Here, the patient can't retract the scapula and can't do these movements of the right side. Here, just the movements, and you have to be aware because the instantaneous rotational center of the scapula is it becomes lateral in elevation. Then what is exams and diagnostic are you going to do in this case? Please, Fernando.
Well, it looks like a winging scapula. Tough to say.
Yes.
From here, but I think it's a winging scapula.
Basen, what exams do you like to see? Basen?
Okay. Do you mind to go to the very first video, the motion of the patient?
Okay. This video, I think, let me just make it.
So the patient can flex her, yes, the patient can flex her shoulder all the way up. That's correct?
Yes.
Yes.
But after it's over 80 degrees, it's not stable anymore.
Yeah, I understand.
And
so
the scapula wings.
Yeah, I don't call it wing. From now on, I have different terminology. I call all of them STAM, S-T-A-M, scapulothoracic abnormal motion, because this way we don't say anymore dyskinesia and winging, and there's a confusion which one which. All of these are STAM, scapulothoracic abnormal motion. Done. Then we have to figure it out. What's the problem? How are we gonna figure it out? What we're gonna do for it, regardless. Okay. So it does have an abnormal motion. That's correct. If you go to the next video. Sorry, the one after. The next one, Jose. Oops.
The last one.
Yeah, there's another one.
For here.
Yes.
This one?
Yeah, this one. So notice.
Sorry.
Yeah. If you notice at rest, look at the scapula tip. She's not moving. Okay, she's at rest. If you think about it, at rest, why the scapula looks slightly tilted forward? This is a bigger question. Is it because she does not have the middle trapezius or portion of the upper trapezius? It could be. I think it's a combination of problem. I do think she developed over time pectoralis minor hyperactivity. This is why she's tilting forward. And the fact that she does not have a retractor, enough retraction from here to pull the scapula backward, will put her like in this kind of position. And this is mostly for me adaptive. This is adaptation. Now, what I would do for this one is different than what Jose is gonna do for this patient. Because if you look at this, if you want to convince me this is trapezius, explain to me why she is having this prominent scapula with the push-up test. If this is a trapezius, right? I can show you a lot of videos of completed trapezius paralysis, and patient, they can do the push-up test and they don't have much abnormality, much STAM or winging, if you want to call it. But notice now she's doing this and she has just a huge prominence. And look at the scapula, is not completely normal, is not completely like sitting on the chest. So this patient has some issue with the abnormality of the musculature around the scapulothoracic area. Definitely the trapezius has to do with it, but this is not only this problem. This has been said, she's one of those that you can do maybe a number of smaller surgeries, and if she is really kind of psychologically ready to have it done, she may do well. Anyway, so in short, this patient has, for me, some deficiency probably in portion of the middle trapezius, and maybe lower because I can see portion of the lower trapezius. and she has an abnormal pattern of scapulothoracic motion or abnormal scapulothoracic activation. Part of it is a pectoralis minor hyperactivity. Part of it is a maladaptive use of the scapulothoracic area. This is my diagnosis.
I felt some. Sorry.
Professor Bassin, have you ever treated those patients with pec minor release?
Have you? Any one of you have been in Annecy last year? If I'm, have you been to Annecy?
Yeah.
Okay.
Yes.
Yeah. So I have a patient almost duplicate to this one, even almost the same body habitus. She is a yoga instructor. She understands very well her body. She has an absent lower trapezius. She's not doing as much this, but she has exactly the same pattern of abnormal motion, inability to retract the scapula completely. And in this patient, what I've done for her, which is different than what's done here, I did for her pectoralis minor release, but I added also something called scapulopexy. What is scapulopexy? I know it's not the purpose of this presentation. Scapulopexy is tying the tip of the scapula to one of the ribs. Now, when you hear it, you say, what are you doing? What do you mean? Are you fusing? No, this is not fusion. This is just only holding the scapula slightly on the chest. This tendon will stretch within 2 to 3 months. It will not affect the motion whatsoever, but it will keep the scapula in a good position on the chest meanwhile. And the patient learn how to activate the sequence of muscle around the scapula much better. Because if you notice, this is not a normal motion. Not because of the trapezius. Look, it is not a very normal motion. There is an abnormal sequence of event. The best way I tell the patient is, if you ask the same patient, raise your left arm, she can raise her left arm with 1 second. But during this 1 second, you have at least 8 to 10 muscle working in sequence to get you this very nice smooth motion. If, as she's moving the right arm, she gave this order, and instead of having from 1 to 10 muscle going 1, 3, 2, 5, she's going to have this kind of abnormal motion. And this is my opinion what's happening with her. These are very tricky cases, by the way, and thank you, Jose, for presenting it. But these are very specific and tricky cases.
Tricky. And I think in my opinion, the rhomboid major is maybe involved on this problem.
How do you know?
I know. Well, by exam, I thought, but the exams were like these electromyographic studies with very poor.
Yeah, I don't believe that. I'm sorry. Like electromyography, is perfect. You can examine and you can know. I'm sorry, with all due respect, because if you examine this patient, the upper trapezius is normal, the lower is not. What does it mean? Is it nerve injury? Whatever? I don't know. Anyway, your exam is more than enough, I think.
Yes, maybe we try to see some small degeneration, but it's difficult to see in this image. The CT scans with no change and bony or other things. And what to do? What you told about scapulopexy, Bassin?
No, not only scapulopexy. I said 2 things. Honestly, what I do in these patients are, so I'm going to tell you the sequence of what I have in my thought. This patient, let's say you did EMG and showed some abnormality in the serratus and trapezius, let's say. But by exam, I know she does not. Like, for example, here, where is your long thoracic?
The long thoracic is okay. It's I didn't put here, but it's okay. It's working. From this electromyographic exam, and she did 3 electromyographic exams before, and all with this very same result. It's a tricky case, you know.
I know, but this is why I want to make sure, like, we follow like the thinking process. Why did you do the push-up test for the patient? What is the push-up test for? What is, if in the board exam, resident exam, what's the push-up test for? For the serratus. I don't do it.
Yes.
I do testing. For the serratus, not for the trapezius. This is like board exam question, resident, all of them. I don't like it because for many reasons. I have my own set of exam. but for the serratus. So if someone see this exam, for me, if you send me this video without history, I will question the serratus. Doesn't matter what the EMG will show. Just hear me out. Let's say this is my patient. I saw this one. I told her, like, EMG looks okay. I can trick by exam to know, because how would you know this exam is truly abnormal or not? When you do the push-up test, she's having this huge stem, boom. But when she's flexing, she's able to stabilize the scapula in a certain way. So this usually when the serratus function the most, when you go from flexion almost from 90, almost below 90, and then you go above 90. If above that, the weight of the arm push on the scapula and the scapula goes out, you know the serratus is not working. And for me, this is why I know the serratus is okay. But let's say you say the patient she's worried. I can make very small, tiny, regardless, I'm going to do the scapulopexy through the small incision at the tip of the scapula. This whole thing takes 10 minutes. You can see latissimus, which you want to use. You can see the serratus, and you can examine it intra-op. You can take a quick video and you examine it. It looks perfect. Then after surgery, you tell the patient the serratus is perfect. Look, this is a small video. Look at it. It's perfect. Then, for me, what I do pectoral spinal release arthroscopic, and I do the scapulopexy, and I let the patient rest. And with this specific category of patient, they've done well. But if you have another way to retract the scapula backward with another technique, it may work as well. So,
well, we had a very long discussion about it. Some from accessory nerve lesions. That's a very old procedure, Aiden lunge, and a very new procedure of Bassen triple transfer, when we transform the rhomboid major as a rotator. But you don't have any action over the latissimus dorsi that remains, bringing scapular to the medial tilt and down. Here how the center of rotation of the scapula works, and how latissimus works in all this center of rotation parts. And we have in this case an idea of doing the partial lunge with superior part with levator scapula to lateral, rhomboid minor to lateral. We remain the rhomboids to major to try giving some retraction, and use the latissimus dorsi as a synergic group of muscle of the lower trapezium. This is the surgery we are proposing in this seminar. Here is the latissimus dorsi. Then we first do our first approach for the portal. As you don't have any cavities on this region, you have to do a cavity, subcutaneous cavity, and then we insert a robotic optics in this part. Here is how the surgery works, how you make the surgery. Here is the surgery, how the robot works on the surgery. And here's the section. Here's a subcutaneous dissection over the latissimus and the teres major. Here teres major, here the latissimus fibers. As you can see, going to under the triceps. It's a very sensitive part. Here we are cutting the teres major adhesions or to latissimus dorsi, and cutting the latissimus dorsi from its origin. The radial nerve is just below, and you have to take care. Here we try to continue releasing the latissimus dorsi. Here's the latissimus dorsi release, and you can manipulate it better. Here you can see the axillary nerve is just after this fat. Then you make some suture, continuous suture in the latissimus dorsi tendon, and you pull the latissimus dorsi tendon out through the optics portal. Here, just pulling out using this, and then out of the body, we can bring the latissimus dorsi. You do another small access to the scapula, to the scapular spine. Then another small approach to levator scapula and rhomboid minor, used to remove these muscles with the osteotomy to have some part of the bone to make a better connection. Then we transfer subcutaneously the latissimus dorsi to the scapula and the levator scapula on the right side. We suture all these muscles in the scapular and the spine, and here's done. Here's the patient, 7 weeks post-surgery, 11 weeks post-surgery, all these movements. And here is the pre-operative and post-surgery movements of the scapula of the patient. She is with no pain, she's very happy at this moment. Thank you.
Very, very nice. Very, very sexy, very nice. Do you have only a minute for me to share my screen? Only 1 minute?
Yes, please.
Go ahead.
Okay. Can you see my screen?
Yeah.
Okay. Look at this patient. And I have at least 40 of these, so different presentations. Look at her scapula. Look at this patient.
Yes, but it's very different from that one that I presented before. The scapula was not so.
Yeah, but
winging.
what about this? What about this one? All what I'm trying to say, Jose, like all I'm trying to say,
More like
the technique you've done is very, very nice. I'm just showing a certain time, like this is the tricky part about these kind of patient. And you have like this one, for example. This patient is slightly different because he is forwardly pulled forward. And whenever they move, this one is not as dramatic. This is almost like your patient and able to flex even better, but you can see how this winging go out, and his lower trapeze is not very prominent. And this is how I know whether or not they're gonna do well pre-op. This is one of the exam. But this patient, for example, this is all these patients, now I have at least probably close to 50 of these. We do arthroscopic pectoral spine release, which all of you do. I'm not going to spend time on this one. Any one of you know how to roll trapeze. This one take 5 minutes, 10 minutes maximum. And this is a scapulopexia.
I told her about the pec minor, that it would be an option for a second time surgery and endoscopy.
So, see here, this is the one I'm telling you about, because you can see this is take 5 minutes. You can see the serratus, latissimus, everything else, and you can examine the latissimus for the patient. And you can expose the rib at the same level, and you can use hamstring if you want to. We have an allograft, and I pass it around, and you pass it around, and you suture it, and tie it, and let the patient rest for 4 weeks, and that's it. And this scapula can still move, but doesn't wing as much out. And this is the same patient. Look, and this is her 6 weeks after surgery. She went back to taekwondo. And this is the other patient. Again, the same. So they do extremely well. This patient was not able to move her arm at all. But all that I'm trying to say is this is very sexy technique, and I don't think I've seen anyone else done robotic surgery before, which is I applaud you for this one. Honestly, congratulations, because I don't think anyone up till now in our world to try to do a robotic, especially for soft tissue. So this is absolutely fantastic. Hopefully there are going to be application for it in the future more and more. If anyone is going to be like, probably you're going to advance it in this field. All my point is this is a good idea. The only thing, if we want to try to truly understand the pathology of this patient, I'm not very sure we still know exactly well what's happening before surgery, why her shoulder was behaving this way. It does not matter. She did great with this surgery. This is all that matters. So
yeah. Good for the results of her.
I would congratulate you, Garcia, for the technique, but I'd like you to know what's the exact advantage you use in robotic in this specific case.
Yes, the advantages are cosmetic. Cosmetic is an advantage for this patient. This patient is a girl. She was looking for something different, and we don't have so many scars. We just use subcutaneous release. Then it can make it better for the recover. You see that this patient had 11 post-operative days and was doing very well. I think these are advantages. I think it's the same advantage in the beginning. In the very beginning, we had from arthroscopy over the open surgery. We are developing the technique, but I think this is a good start, a good begin, and you can continue evolving this technique over time.
Jose, how long did it take the surgery?
What?
How long did it take? Because the first time usually takes longer time whenever you do something new.
Yes. The first time was around, the robotic part was around 4 hours, like the first arthroscopies, I think. Then we had some complications, not, but you know, it sometimes become very you feel bad because it doesn't go, but it's becoming faster and faster. We have now 3 or 2 hours of this surgery, and you don't have the most specific tools, but we are trying to become faster, and maybe we'll try to get it in 40 minutes. I think this is our goal in the future.
How many have you done?
Well, from this, I think we have 8 patients.
Wow, congratulations, awesome, very nice.
Not this technique, all right? I did some latissimus dorsi trunnion for massive rotator cuff tears, and I know you don't like this, but this was the first one.
It's like I used something different. This is what I'm saying.
Okay, our time almost going out. The next case, Fernando, could you present shortly this case, please?
Okay, this is a female patient, 66 years old, with right shoulder chronic pain and dysfunction. On physical examination, she has passive and active normal range of motion, but painful, and all subscapularis tests are positive. We can see here on her X-ray, it's a quite normal X-ray with a quite normal supraspinatus, a very large subscapularis tear with a long tendon, meaning probably there is a chronic disease on subscapularis and subsequent tear with degenerate belly. Look at anterior wall of the rotator cuff is gone, and so its diagnosis is a irreparable subscapularis tear. And what we've done for her is lateral dorsal transfer for irreparable subscapularis. So going to a dactopectoral approach, conjoint tendon, we can see the head moving forward, as Professor Besson says, a dynamic instability. When we sternal rotate, the head go superior and anterior. We can see the lat dorsal tendon. We do a small tenotomy of pec major. We have to detach lat dorsal from teres major. Them sometimes are almost like a conjoint tendon. This is a very important step. We put 2 Krakow stitches, prepare the bone bed on lesser tuberosity, and our goal is going upward almost to the greater tuberosity. We do some transosseous suture. You can use anchors if you so desire. Some transosseous sutures through the humeral head and lat dorsal, and also we can repair the stump of the subscapularis in the lat dorsal to increase the anterior wall. Here we can see an anterior supraspinatus tear. Then we repair it with also transosseous suture. And finally, we sutured the pec major. Here is a draw showing our technique and the patient with 6 months follow-up. She's very happy with her function, with no pain. And what we can see is, I don't know if Professor Bassan agree, all the subscapularis tests still positive. They don't recover the press belly test. They still have bear hug tests, but what we see, they have very good forward elevation and a painful shoulder. Okay, thanks again.
Fantastic, Fernando. Really, very nice work.
Thank you. Thank you.
Yes, I agree with you. Honestly, I'm not very sure whether or not we can reverse fully a lift-off test. So what I noticed in patients, they improve it, which means if you want to put the hand really behind the back all the way up and lift it, they cannot do it. But if you ask them to put the hand behind and lift it, they can do a modified lifting test that is better than before. But some patients, they do it, I don't know, and some patients are not. At the very end, this is not the subscap. And for me, I cannot always guarantee they're gonna get all of these reversed. The pain improvement, the range of motion, the strengths of internal rotation, they do improve. These specific tests, they don't improve specific for me. Now, this has been said, I wonder whether or not we should come up with a different test for this kind of transfer. What I mean is, even though we say external rotation, there's a huge difference between external rotation and internal rotation. External rotation, because many times patient cannot external rotate. Internal rotation, it goes from neutral to belly. Everyone can do it. And behind the back becomes slightly harder. It's not as clear how we do the internal rotation. So I think if the patient have an improvement in the strengths of internal rotation and able now to be able to put their hand behind their back with ease, it's considered relatively a good outcome, not an excellent or outstanding outcome. But I think for the subscap, reconstruction is not a bad thing to have because it's very difficult muscle to reconstruct.
Yeah.
Okay, our time is over. Unfortunately, we have no time for another case. Sorry, Garcia. I'd like to thank you, all the panelists. Special thanks for Bassan for having with us. Thank you, Fernando. Thank you, Garcia.
Thank you.
For a very nice case, and thank you for Kekia for share with moderate in this discussion. Thank you very much. Obrigados a todos pela participação. Stay safe. Bye.
Bye. Ciao.
Bye bye. Ciao.
Bye bye.